This is part 2 of cardiopulmonary rehabilitation. Lots of objectives here. Go ahead and pause and read them. This will be on your testing. The overall goal is maximize functional ability and minimize the impact of disability. And its definition is the restoration of the individual to the fullest medical, mental, emotional, social, and vocational potential. Here are some other goals, and that is about quality of life and improve symptoms. We're a very young field, and we're not doing a whole lot back in the 50s and the 60s when these scientists were suggesting that patients needed to be reconditioned, and when the value of that was being demonstrated. Even then, we were thinking about how to improve their lives and how to keep them from getting sick and coming back into the hospital. Having a diagnosis of COPD can be depressing, and some of the medications play into that as well. Steroids certainly do. And your patients with COPD have dyspnea, and dyspnea causes anxiety and stress. So we do need psychosocial support as well as physical conditioning. So it depends on where the patient is, but you have goals for pulmonary rehabilitation. And these goals form a task list of various education that the patient has to undergo during pulmonary rehabilitation. The first thing we have to do is make sure we have the right patient for pulmonary rehabilitation. So your patient has to be evaluated for multiple reasons. Your contraindications are those who can't do it, period. So if they can't perform the tests that are required to evaluate them for it, remember, severe pulmonary hypertension often is idiopathic, and until we reverse that condition, they're not going to be able to tolerate physical reconditioning. Blood pressure raises as people work out, so if they have untreated hypertension, we're not going to be able to take care of them like that. Neuromuscular disease is generally chronic, and so pulmonary rehabilitation is not indicated. Also, asthma that has not been stabilized or treated. If they're in an acute episode of asthma, they do not get pulmonary rehabilitation until they're stabilized. There's a difference between unstable and stable asthma. And of course, angina with exercise means that Your heart is not getting enough oxygen. So if you exercise them, you're going to stress that system, so they don't qualify. Your big diseases for pulmonary rehabilitation are COPD, chronic bronchitis, sometimes cystic fibrosis patient, people with bronchiectasis, and some asthmatics. Contraindications: you cannot do pulmonary rehab and work on their exercise if they are unstable, cardiac instability. You also can't rehabilitate cancer. So we need to take care of the cancer, if we can, before they qualify for rehabilitation. If they have terminal cancer, think hospice or palliative care instead. Patients with various physical deformities may not be able to do a lot of the tasks that are involved in pulmonary rehab. So with those patients, neuromuscular abnormalities and severe arthritis, we need consult from other therapies. There are two types of rehab programs, and you'll see this on a test. Open-ended designs, those are where a patient comes into the program with goals that need to be met, and the program keeps going until they meet their goals. A closed-ended design is basically the opposite. They have a certain amount of time that they can go, and the goal is to reach those goals before the time expires. And it is a set period of time, and that is more common. The outcomes must be monitored to prove that what we're doing has been successful. We have to justify our existence. By following up, we remind patients about what they learned, and we make sure that they continue to practice the best practices that they have learned. If you have a time limit, which you probably do, you plan your meeting so that you accomplish certain goals. Generally, when a group meets, they need a few minutes to socialize a little bit and get settled. So that will be your group interaction and welcome. They will chat. And these examples are of the educational, so the cognitive part of this. The physical reconditioning would be the psychokinetic. And then attitude has a lot to do with participation. And so this is an example of a 2-hour pulmonary rehab session that may occur between 1 and 3 times a week for a limited period of time, or it might be open-ended, but this is more for a group session. Physical reconditioning, they do upper body and lower body exercises, and there's a big print down at the bottom. An initial target heart rate is 20 beats per minute above the resting heart rate. You will see this on a quiz, undoubtedly. So if my heart rate, for example, was 86 at rest, my target would be 20 above that. We commonly divide into upper body exercises and lower body exercises or conditioning. So the lower body exercises would involve something like a stationary bike, and of course that 6 or 12-minute walk that we do to evaluate how well patients are doing. The upper body exercises are upper body aerobic exercises, which can be either done in a chair, various forms of chair and upper body, or they have a little pedaling machine where you can actually use your arms with that. This is important because sometimes patients need to do a lot of upper body work, and when you're not sick, you don't realize how much work it takes to do simple things like comb your hair and brush your teeth. Ventilatory muscle training with progressive resistance, those are the two devices that I put down below. And what it does is that you exhale against these devices, and as you get better and better at it, we increase the resistance so that patients can get trained in using the muscles to exhale. This is great for patients who have a hard time exhaling, like COPD. As far as education, we want to tell them about the pulmonary system. Remember that not everybody knows everything about the lungs, so we're going to talk about what makes the lungs work, and then we're going to move on to different forms of how to take care of your breathing, relaxation, because you can get anxious if you can't breathe well, and then various exercise techniques. And that is individual for each patient. So we're going to talk about all of those, but then we're going to work on them individually with the patients as well. Bronchial hygiene is how to cough and clear your secretions. Different things work with different people, and it depends on your disease processes. So that also is individualized. In pulmonary rehab, they're going to teach about oxygen and safety in oxygen, any medications the patients might need to be on, how they should be eating. And the final thing on this page is recreational and vocational counseling. And that, not every patient wants to stay at home. They may want to return to work. They may want to think about a different career that is more forgiving of their debility, and so that's part of the program. As far as recreation, if you have limitations, then what kind of recreation you might be able to complete, and that helps the patients have a fuller life. Any patient with a chronic and or long-term or terminal diagnosis is going to have a lot of emotional stress, and we have to meet the needs for counseling and coping methods. And it's better to have an expert. I don't want to be the respiratory therapist and counselor, although you end up sometimes talking to these people because you have a relationship and they trust you. And at that point, if you feel especially as if it's more than you can handle with them, and I suggest immediately, if they are talking to you about anxiety and stress, let's get them a professional. This is a program that not just the respiratory therapists run. So you are going to be working as a team with lots of different people. Remember, these patients are medically more fragile than the average population, so different forms of life support is ideal. And as a respiratory therapist, you're going into this field with BLS and ACLS at the very least. Here's an example of the team. As far as facilities, think about the kinds of limitations that your patients are going to be facing. Some of them can't climb stairs, so having a ramp or an elevator into your facility is crucial. Your rooms cannot be too small. Patients get claustrophobic, and you may have large groups, so it has to be able to handle a large group. If patients have various needs that they want to keep private from the greater community, that's why you need a separate room. So if they have a little emotional breakdown or they have specific things that they want to talk about that they don't want others to know about for privacy purposes, an extra room is a good thing. And taking them into the break room where the coffee machine is not privacy. You do not want to schedule pulmonary rehab sessions for the great majority of these people at a time when they're going to have to be facing large amounts of traffic. Having your appointments, when most of the people working 8 to 5, 9 to 5, 7 to 3 type of jobs are not there, will help them in their ability to get to the place. And you have to talk to your patients about what is convenient. They will make appointments. You will have classes scheduled so that they can plan on this. The other thing is that you may have a high proportion of people who do not drive anymore. So they have to be able to get there. We have public transportation that's available, but that's also a consideration when it comes to scheduling. Sometimes your patients end up waiting in the lobby for a long time for their ride to get there, or waiting a long time for the class to start because their ride has delivered them early. So we have to be able to accommodate those needs for that patient. Remember your ideal class size, anywhere between 3 and 15 patients. Above that, and you can't pay one-on-one attention like you should. Below that, it's not really a class. Your classroom environment needs to be a place where people that have various disabilities can learn comfortably. This may mean that they have a place to write, they have a comfortable chair to sit in, they have to be able to see and hear. You have to be able to write just as you would in a classroom. For the physical part of it, that is the lower body and upper body exercises. So whatever it takes to make sure that's done. In addition to that, you have to be able to monitor your patient. So a pulse oximeter is a good thing to have, because when they desaturate, you must stop their exercise. Various pieces of equipment. The other thing is what happens if your patient develops a sudden oxygen need, or if your patient runs out of their own oxygen. So having oxygen in the room and available is important in a rehabilitation program. It's expected that we monitor patients' progress. And we've talked about several of these things. Until we monitor it and document it, then we are not documenting that there is a benefit from going through this program. If we justify our existence of rehabilitation by demonstrating that this saves patients from being readmitted into the hospital, that they are benefiting from it, that it's costing less money on the end run, then we're going to have more buy-in from the community. Be aware that patients can develop various problems during their exercise. They haven't been used to doing this, and they can develop problems. So remember that a lot of people with lung disease will also have cardiac disease. that if they're huffing and puffing, they're generating more carbon dioxide and maybe using up too much oxygen, and so your blood gases are going to change. It's hard to do if you don't have a blood gas machine, but you can assume. And remember that if you have a patient that has exercise-induced asthma, it's an opportunity for education. Some patients get a little hypoglycemic when they've worked out, and we have to have our snacks for that reason. And of course, dehydration. Let's get them some water. Remember, their blood pressure will go down if they're dehydrated. Respiratory therapy staff can also be involved in cardiac rehabilitation as well, and sometimes they go hand in hand. It's ideal to combine what we do with other things that we can do. So that would be smoking cessation classes, asthma education, cardiac rehab. So all of that can be held in the same facility and sometimes at the same time as an addition. What we want is continuity of care. There are 3 identified settings by the NBRC: hospital, rehab, and home care. All of those are places where the respiratory therapist is present and can work with patients. Most respiratory therapists work in the hospital, so we start at the bedside with education and rehabilitation in the hospital with each patient. Those are our objectives down below. Some of this is about quality of life. If you don't feel like you're as dyspneic, then you feel better and you do more. Your life has better quality to it. If you are more able to take care of your own self, your life feels better and you feel better. And the final thing is decreased frequency of hospitalizations. And I will tell you, nobody wants to be in the hospital, and the hospitals don't want you there. Here are some of the techniques we have been discussing: pursed-lip breathing, diaphragmatic breathing, and cough control techniques we discussed in your last lesson, and there are videos about them. I suggest you watch them. Exercise conditioning we just went through. This is improving their ability to go on with their activities of daily living. And then nutritional balance, I want you to remember these facts: increase the protein and fat, decrease the carbs. Carbs, as they burn, increase the CO2, and it can increase the dyspnea or the inability of the patient to process carbon dioxide. So remember, increased protein and fat, decreased carbohydrates. Remember, it's multidisciplinary, and everybody has their own little tasks. Exercise is more about what we do with them, and physical therapy is great in participating in this as well. We work as a big team in this, so it depends on where you're working. Remember your 6 or 12-minute walk. That's your timed walk test. Please read the blurb below. We titrate their oxygen while they're exercising. They may have an exercise oxygen prescription that is higher than their oxygen needs when they are laying down at home. So they may have to turn up their oxygen while they're exercising. This gets better, or could possibly get better, as their exercise tolerance changes. Just remember, if their oxygen levels go down, they can go into anaerobic metabolism, and that can cause acid-base disturbances. So we need to make sure that they're getting enough oxygen while they're walking around or doing anything. We're going to assess the patients before we do their exercise. You need to know if they're having problems, first of all. Second of all, you need a baseline so that you can compare it to what's going on if they should develop dyspnea or pain or chest pain. At the point where that happens, you're going to reevaluate your patient. You can do oximetry, respiratory rate, and blood pressure without much of a problem. Heart rate just takes a watch. And the EKG, you'll probably do something that's relatively remote. You're probably not going to follow them around with an EKG machine, but you can put patients on a Holter monitor and monitor them remotely. And of course, if your patient is having pain or stiffness. That's it. This is the last slide.